It gives me great pleasure now to introduce our international guest speaker. You'll notice from his accent that he's British, but Professor Duncan Lascelles comes to us today from the College of Veterinary Medicine at North Carolina State University. He's a true clinical academic. He's here to talk about his research into naturally occurring models of animal pain in translational research, but he's also a professor of surgery and pain management. So give a warm British and RSM welcome to Duncan Lascelles. Thank you.
Thank you very much for that introduction, and good morning. It really is a pleasure to be here. It's an honor to be here, and also a pleasure and honor to see so many people that I have worked with, colleagues that I've worked with and learned from in the past. I work at North Carolina State University, and I've spent most of my career, started off in the Bristol Pain Group at the University of Bristol, and most of my career since then working out ways to measure pain in companion animals. And increasingly, over the last few years, I've been involved working with pharma and bioindustry, biotech, biopharma, both on the human, if you like, and veterinary side. And the reason for that is what I'm going to talk to you about today, which is essentially a concept, but it's a concept that is actually working in practice. And this is the use of companion animals to inform translational pain research. And so, you know, one way, there are different ways of looking at every subject, depending on sort of the spin that you put on it. One way of looking at this is translational preclinical chronic pain research. Preclinical as in before humans. And we're going to be talking about... Sure. We're going to be talking about companion animals, their use in that, and looking at some of the hurdles, but also the comparative opportunities. And so, yes, I will be talking about dogs and cats, but you'll see that my comments are very much from the perspective of using knowledge we can gain in them to inform translational pain research. Just as way of introduction, I don't need to tell any of you about the economic impact of persistent pain. The 2011 Institute of Medicine report suggested the economic impact of persistent pain in the United States was $600 billion a year, more than the economic impact of cancer, cardiovascular disease, and diabetes combined. And these are big figures, you know, and you can certainly question the exact amounts. But regardless, the economic impact is significant. The amount of research done into pain mechanisms has been exponentially increasing. This is a chart from Percy Dessert and Andrew Rice's review. And yet, so despite the economic impact of persistent pain, despite the exponentially increasing amount of research, there is overall a failure to develop new analgesics. And we've heard that already this morning. Burgess and Williams, this is a little bit old now, but essentially said that in their manuscript, they said over the last 20 years, there have been no new analgesics developed for certain chronic pain conditions, including musculoskeletal pain. There have certainly been developments that have been variation on a theme, but very few new analgesics. And they called out the alpha-2 delta modulators, zinconitide, some of the cannabinoids and TRPV1 agonists. Where does translational pain research go wrong? And don't worry, I'm not going to dwell on the depressing parts, but I think we just need to, you know, think about what translational pain research is. Drug discovery is extremely important. At the end of drug discovery, you start clinical trials. Phase 1, essentially the safety. Phase 2, proof of concept. Phase 3, the pivotal studies. And there are many places along this process where we could look to say, okay, you know, what's gone wrong? We could even point the finger. One of the areas that has received a lot of attention is the preclinical aspect, the drug discovery to identification of the NCE, the new chemical entity, or the putative analgesic. And many Many reviews have written about this and discussed, what the problems are. Is it the models? Is it the outcome measures used? Is it the lack of transparency in reporting? Do people only report the best data, which gives a false sense of security in molecules? But it's not just the preclinical side. Certainly we could challenge what is going, how the clinical trials are performed. They're not particularly sophisticated, and they're becoming more so. They're not particularly elegant. They assume patients are all homogeneous. The diseases are homogeneous, and they are not. Even osteoarthritis is a very complex disease with subgroups. But instead of talking about where does preclinical pain research go wrong, let's maybe think about where could preclinical translational pain research benefit. And what I want to touch on here with respect to companion animals is the idea of enhancements to the models. Okay, so the pain state that is being looked at, that's what I mean by a model, the animal pain state combination. Also outcome measures. What I mean by that is what you use to measure that pain state, whether you're measuring pain or change in sensitivity. And then also touch on this idea of the relevance of the target. Okay, and hopefully that will become clear as I move on. If we start with the model, here's a quote. It's isn't it awful to quote yourself? But I think it sums up what I want to say quite nicely. One can ask whether peripheral nerve injury, the acetic acid writhing test, the orofacial injection of formalin, or the intra-articular injection of Freud's complete adjuvant actually mirror any clinical conditions. Certainly on the veterinary side, I have never seen patients that are suffering from intraperitoneal acetic acid administration. Now if you did, I think they would be very relevant models. This is a bit tongue-in-cheek, but I think you have to sort of look at the models and say, okay, do they really mirror the clinical conditions? This is me putting complete Freud's adjuvant into a rat paw. I use these models in my pain research. But does this really model, does it reflect what's going on in, say, this gentleman here, an older gentleman who's suffered for decades with knee osteoarthritis? And you may say, well, of course not, and no one's going to assume that, or no one's going to advocate that this does model osteoarthritis, and yet that connection is made. I've worked enough with industry to know that connection is made, that there is that leap from these sorts of models into the clinical condition. I just, right at the very start, I was looking around and I didn't see one particular individual, and I just want to acknowledge that my little sister is here, and this is an amazing moment in my life. For the next 25 minutes, I have her uninterrupted attention. She's a physician on the South Coast, so it's lovely to have her here. Okay, so those are the models. In terms of outcome measures, as you've already seen, a lot of the outcome measures are these reflexive tests. And so here's a YouTube video of the Von Frey test. And I think, they can be questioned in two ways. They provided us a lot of information, but can be questioned in two ways. Firstly, do these reflective tests mirror the affective component of pain? Do they actually tell us about the feeling of pain, or are they a measure of sensitivity? They're obviously a measure of sensitivity. But then also, and this was touched on earlier, Professor Anand showed a slide in human neuropathic pain patients that was showing hypoalgesia, which is one of the most, that's the most common clinical presentations, and yet the models mainly rely on hyperalgesic states to test analgesics. So, I think we can certainly question some of the outcome measures, the common outcome measures. And then there's the relevance of the target. There are so many molecules, receptors that are involved in producing and driving persistent pain. And for someone like me, looking at Santosh Mishra's work here, describing all of the receptors on a TRPV1 expressing neuron, this is like Christmas for me. I mean, there are so many receptors. There's so much work. There's a lifetime of work, lifetime of molecules, pathways to get involved with. But at the same time, it could be a little depressing because there is so much redundancy. And if you focus on just one of these, just focus on that pathway, you may not see the clinical efficacy, which is what we're looking for, unless, of course, it's a very important player. And I know Professor Dickinson's going to talk about one pathway, that the nerve growth factor pathway, that has turned out to be an important player on its own. So, I give you a proposition. Companion animals with a naturally occurring painful disease may enhance the translational pain research paradigm. And one of the reasons I think this is exciting is that I believe these naturally occurring painful disease models may better reflect the genetic, environmental, temporal, and physiological influences present in humans. That's on the positive side. On the negative side, they are complex, genetic, with a lot of environmental, differing temporal, and varying physiological influences. And that means they're not homogeneous, they're not consistent, which does make them more difficult to manage and to deal with. So there's a plus and a minus to that. If we think about, now if we look at the translational research paradigm in a slightly different format here, we've got identification of putative targets and compounds. Basic activity is established, testing safety. Pretty much has to be done in a small and large animal species, which tends to be one rodent and the dog. And then you go on to human clinical trials. What I'm going to talk about are the role that companion animals with naturally occurring disease may play in informing the critical go, no-go decision point, okay? And that is, maybe it's here, what chemical entity do you take in, or biological entity do you take into phase 1 studies? Or in phase 1 studies, which one do you move forward into phase 2? Because this is where the process starts to get expensive. And you all know the cost involved, up towards $1 billion for the whole process. And then at the end, I'll talk a little bit about discovery back here, how companion animals may help inform discovery. As an example, to kind of base my comments around and kind of convince you of this concept, I'm going to use the example of osteoarthritis pain. So if we start off with the model, I believe naturally occurring osteoarthritis in dogs and cats does have fidelity with the human condition. It's biomechanically, structurally, histologically, genomically, and molecularly similar across the species, whether it's human, canine, feline, and equine. Absolutely, there are some differences. There are some nuances here. But essentially, you're looking at a very similar disease. You can see here, just as a radiographic example, the human coxofemoral joint and the canine coxofemoral joint. And however you look at these two diseases, they are very similar. And importantly, actually, they're as similar in terms of what is driving the pain that can be associated with this. I think another way of looking at the model fidelity is just to look at the patients. And I think if you look at these two, and this is actually my father who suffered widespread osteoarthritis, and this is a dog with widespread osteoarthritis. They look similar. That stilted, uneven movement that is caused by pain on ambulation. And so again, I think, I'm not, as Jeff Moger would say, I'm not throwing the baby out with the bathwater. We have to use the rodent models, but I think there is potential here for enriching the translational research paradigm. However, these models are no good unless you can actually measure the impact of pain. And if we look at chronic pain, and if we look at the dimensions that are impacted in humans, I've tried to illustrate them on this slide here. Everything from gait, movement, activities of daily living, sleep, cognitive function, social relationships, somatosensory processing. All of these things are impacted by pain. So in a human, you can say how much pain are you feeling. In animals, you can't. So you have to measure the dimensions impacted. And what I'll show you in the next few slides is that we have the ability, and we're actually pretty good at measuring the impact of persistent pain on gait and movement, on the activities of daily living, on sleep quality, cognitive function, even the affective domains, and somatosensory processing as examples. And so starting off with gait, why do we measure gait? Well, because joint pain affects limb use and affects gait. The first two videos here, you can see this is a pressure-sensitive walkway. We're looking at body weight distribution across the limbs, and that is affected by joint pain. You get decreased, see the green here, decreased body weight distribution to a limb where there's a painful joint. We are extremely good at measuring limb use using force plates. So these are Julian series AMTI force plates. I can just go back. That's all right. And we can measure, we get 19 different parameters basically relating to the X, Y, Z coordinates. So vertical forces, craniocaudal forces, and medial-lateral forces. In fact, you know, we in veterinary medicine, in companion animal research, we are far better at measuring limb use than what is possible in rodents. But that is a long way behind what has been done in dogs and cats. If you can measure limb use in cats. It's pretty frustrating. Trying to get a cat to walk down a catwalk at a constant velocity at plus or minus 0.2 meters per second squared is somewhat difficult unless you're dragging a can of tuna down in front of it. I didn't want to leave you thinking that this is easy work, okay? We also have done a lot of work measuring activity. This is something that I think is just starting to be seen in the literature on human subjects. For about 15 years now, we've been using various accelerometers. And they can produce a lot of data, and you can manage that data in different ways. We use the accelerometers in this study here as a proof of concept study to show the analgesic efficacy of an anti-NGF monoclonal antibody in this naturally occurring feline model of osteoarthritis. And you can see the dramatic difference here between the treated and the placebo animals. This is just an average change in activity count per minute from baseline, so we collapsed the data down. The effect of anti-NGF in this model was so great that we saw that effect with a very simple statistical approach. But animals have patterns of activity, and we've used functional data analysis to look at patterns. And painful dogs with osteoarthritis tend to have lower peaks and higher troughs, meaning they rest less well and they have less intense activity. And so using functional data analysis, you can look at those changes. We've also used functional linear modeling, a similar approach to look at the effect of analgesics on sleep quality in OA pain states. And you know, we're just scratching the tip of the iceberg. Most of these activity monitors involve linear accelerators and gyroscopes. Both of these you see here are showing 3 channels of data at 52 hertz. Every movement that you make has a unique signature when you combine accelerometry and gyroscope data, a unique signature. And so gathering these data, you can actually determine the exact activities that are being performed. And I can tell you, for example, that a jumping cat has a very unique signature in terms of these data, and an osteoarthritic jumping cat has a different signature. And so you can use those as outcome measures to look at the efficacy of therapeutics. The only problem is managing the data. You know, this is over 300 bits of data per second, and jumping doesn't happen that often. And so that's a hurdle to overcome. We can measure function. We measure function, the activities of daily living, using owners. So these are 2 examples here of validated questionnaires. And for those of you who haven't been exposed to this might seem a little, I don't know, arty, not particularly scientific, a bunch of questions that you ask the owner. These are valid in the context of a placebo-controlled, blinded study. When they're utilized in the clinic in an open label situation, there's absolutely going to be a placebo effect, the effect of various other biases. But under blinded, placebo-controlled conditions, these are valid measures of the impact of osteoarthritis pain in dogs. I'm going to touch on these later this afternoon, the Canine Brief Inventory and the Liverpool Osteoarthritis in Dogs Index. We and others, James Hunt is here somewhere from Bristol, done a lot of work measuring, developing methods to measure sensory function through quantitative sensory testing. This publication we did with Bill Maxner when he was at UNC just shows that dogs with naturally occurring osteoarthritis have widespread somatosensory sensitivity, and just as humans can have these tests done, we can do the same thing in companion animals. And these are, just want to emphasize, these are owned pets. These are not research dogs. So they come into the clinic, they have this battery of tests. And what we're going on to do then is to look at the effect of varying analgesics on this. I think it's very easy to think, when we think about osteoarthritis, to think about peripheral sensitization, and we're all comfortable talking about central sensitization. It's important to remember there's a third area, and that's the endogenous analgesic system. And Dr. Bannister is going to talk to us this afternoon about that. And knowing that that's important, we and others have developed methods to measure function of the endogenous analgesic system through what's been called the conditioned pain modulation paradigm. Some people prefer DENIC when you're talking about animals, but essentially this is we apply quantitative sensory testing, you get a response. You do something painful to the animal, and that should activate the endogenous analgesic system, so when you apply the QST again, you get a higher threshold or longer latency. And we found in dogs with osteoarthritis, Eric Tronce's group showed in dogs with osteosarcoma that the endogenous analgesic system appears to be dysfunctional. More recently, we'll hopefully present it at IASP, we've shown that non-steroidals do not normalize. They don't do anything to normalize that dysfunctional endogenous analgesic system. And in our future, in fact, at the moment, we're starting to look at some novel analgesics and looking at their ability to normalize this dysfunctional endogenous analgesic system. Not something I am particularly familiar with, but I work with a colleague of mine, a behavioralist, and we can measure cognition and mood. We can measure cognition and the affective states in companion animals. And so now we can look at the effect of pain. This is, I think, the only study that has looked at, if you like, a pain condition on the affective state in dogs. But we can look at the effect of pain conditions on the affective state on cognition, and then measure the effect of that putative analgesics and other drugs will have on that. So what I have hopefully demonstrated is that because we have the outcome measures, and because I think the model is relevant, we can actually play a role here in testing therapeutics and helping to determine which ones should go on into clinical trials. So you might say, well, okay, that's a nice story. Does it work? I don't have a lot of information for you, but I do have this. Starting to build up this table, and this is a high-level table, okay? Don't worry about the details too much, but pretty much everything works in rodents. Everything that goes into human clinical trials obviously has worked in rodents, because otherwise it wouldn't have gone into the clinical phases. What has worked in dogs in terms of these therapeutic groups has also worked in humans. What has not worked in dogs has not panned out particularly well in humans. Okay, and at the moment, that is absolutely perfect all the way down. A few boxes to be filled in, ongoing work, but it looks like if a putative analgesic works in dogs for a particular pain condition, it will work in humans for that particular pain condition. And so, again, it's this idea of you have, say, if you're a pharmaceutical company, biotech, biopharma, you have 3 potential therapies, okay? And they all look good in the preclinical phase. And you're trying to decide which one to spend hundreds of millions of pounds on. Well, you can spend some money, we'll come to that in a moment, and run these trials in companion animals and make a choice, or help inform that choice. That's what this is all about. In terms of the practicalities, I should probably spend a lot longer on this, but just as kind of a high-level start here, the sites and expertise to run these proof-of-concept studies are there. They're essentially academic veterinary institutions and private practice veterinary institutions. I say veterinary institutions because I do think there absolutely should be veterinarian oversight. These are people's pets, and we need to make sure that there is that appropriate oversight. There are so-called veterinary contract research organizations to help set up and run these studies. My wife works for IQVIA, the old Quintiles, and there's PPD, FAR. There's a whole bunch of on the human side, a whole bunch of companies that will run clinical trials for you, help set them up. Same thing on the veterinary side. And these trials should be run under good clinical practice conditions. That's absolutely possible. And these companies can help set up protocols and agreements and so on. Recruitment is surprisingly easy. Our data indicate that the pet-owning public fall into one of 3 groups, split equally. 1/3 of pet owners absolutely have no interest in being involved. Another 1/3 of pet owners have an interest in being involved because there may be some benefit to their own pet. And the last 1/3 of pet-owning public have an interest in being involved because they're altruistic. They feel there may be a benefit to veterinary medicine. And that's something I haven't mentioned yet, but there's a benefit to both sides here. So there's a benefit to determining what drugs maybe have shown most potential for going into human clinical trials. And by running those studies, we learn what works for companion animal pain in veterinary medicine. So recruitment, I have never found to be a problem. This afternoon, I'll touch on the phenotype aspect. It's important to think carefully about the phenotype. That has to be matched to the outcome measures. If you're using force plate to measure limb use, you need a very particular phenotype. If you're using activity monitors, you can be much looser with the phenotype. This is important. Ethical regulations. There's a kind of an interesting loophole in the United States. You can run studies, as a company, you could run studies using people's pets without any ethical approval. You have to have owner consent, but you don't need local ethical approval. Being in the university, we have to have all our studies approved by the local IACUC committee. In the UK, as I understand it, you either have to be under the Veterinary Surgeons Act, that can be kind of difficult to make an argument for some of the things you may need to do in clinical research, and the other option is under the Home Office, under a Home Office license, which I don't have one, so I'm just prefacing my next comments. I don't think it's that burdensome, I know there's a lot of paperwork, but, you've got to get the site, the personnel, and the protocol license. But I know the Royal Veterinary College has a site license, which they keep active, and that makes them much more nimble in being able to respond to potential studies. Okay, everyone wants to know, how much does it cost? Let's move on to the next slide. I wasn't going to mention it. No, I will mention it. It depends. It depends on how many visits. It depends on the complexity of the measures, complexity of the screening process. But looking back at the last few trials we have run on entities destined potentially for human clinical trials, you're looking at between $2,000 and $4,500 per subject. Okay, so just very, if you had a 6-week study, 3-4 visits, a screening, canine osteoarthritis, and you wanted 100 subjects, that's probably going to come out about $2,000 per subject, okay, to run that trial. That may seem like a lot, but if that helps save several $100 million or pounds, then I think there's benefit there. I'm not going to give you a lot of examples, but partly because I can't disclose everything that they're working on, but we've been working with a company called Centrexin in Boston, and they've been developing capsaicin for intra-articular injection as an analgesic for human osteoarthritis. And you can see here, this is the pain on walking in humans, the reduction there with the placebo, and in red here, the reduction with intra-articular capsaicin, almost looking at a 50% reduction in pain on walking there with the therapeutic. And we've also done work in dogs, very similar profile. Okay, and I just give that as an example to show the similarities between the two models there. And finally, I'm going to touch on this, discovery and face validity and relevance of the target. So now we're going back to a much earlier stage. When you start translational pain research, you have to decide on what system, what receptor, what ligand you're going to be interacting with. And companion animals can be pain phenotyped, okay? When I went through those outcome measures, essentially what I'm saying is we can determine the pain status of companion animals. Veterinarians have unprecedented access to biological samples. Euthanasia happens in veterinary medicine. Pets are euthanized. And particularly where I am, we have various animal shelters that practice euthanasia for population control. Both of those two areas provide biological samples, and those samples can be collected, so there's pain phenotyping of the individual, collect those samples, and then they could be interrogated in either biased or unbiased ways. What I mean by biased is you could take those samples, you can say, I'm interested in X, and look for it in the sample. You're biasing yourself already. You've decided what you're interested in. Or unbiased, things like RNA-seq and the other omics approaches to say what's altered. And so, whether it's samples collected at surgery, whether it's samples collected, this is a dog I've taken off the top of the spinal column. I'm about to collect the dorsal root ganglia here. These samples can be collected, processed appropriately, and interrogated. And we have been doing some work in the last few years. It was by accident. I had dorsal root ganglion in my freezer. Santosh Mishra turned up at NC State. We got chatting, and we looked at the dorsal root ganglion, looked at gene expression, hundreds of different genes. And the one that really stood out as being increased was GFR alpha 3. And TRPV1 expression was up, so were some of the other known pain players. GFR alpha 3 was upregulated, and this is just showing some of the gene and protein expression from the dorsal root ganglia. And then we started to look further. We found that artemin expression was increased in the serum. Artemin was expression, that's the ligand for GFR alpha 3. Artemin was increased in joints. The level of artemin in the joint correlates very nicely with joint pain. And so we've been building up an argument, really, looking at this signaling axis and proposing that this may be something worthwhile to look at. As we were coming to the end of this work, we found out that Regeneron had also been on the same path, and they actually have an anti-GFR alpha 3 monoclonal antibody about to enter phase 2 trials in humans. So they've been very interested in our work, which makes them feel better about the approach that they've been taking. So to conclude, I think companion animal models can contribute to translational pain research in two basic ways. That discovery aspect, helping to decide what's relevant to look at, and this verification bridge. I'm absolutely not suggesting that companion animals will replace aspects of the current translational pain research paradigm, rather enrich it. Thank you.
Thank you very much, Duncan. I'm pleased to hear that killing cats is as much of an issue in the pain lab as it is in our house. Before I open up to the audience, there are a couple of questions on there already. I was particularly interested in your idea that some of these questionnaires are considered to be arty or difficult to validate. And it reminded me of colleagues in the hospital, some especially surgical colleagues, who find it difficult to find validity in in pain rating scales that we use, simply because they have performed a perfect operation and they see their patient having had enough analgesia in their minds, and they can't see why we need to give more against a self-report basis. So on that same argument, the validation of any outcome measure is only is premised on the idea that those collecting the data believe in the assay or the assessment. So the question is not whether it's arty, it's the fact that it is the outcome measure it's the outcome measure for what you're looking for. So is it fair to use it? Is it your job to justify to others that this is the valid score? It's a very long-winded question.
Yeah, no. I think it's a good question, because I mentioned that word arty, and particularly these questionnaires have been developed using appropriate psychometric approaches. Been a lot of work over 10, 12 years in developing these questionnaires, defining the questions, looking at the readability, looking at retestability, looking at concurrent validity, content validity, responsiveness validity. So that's all been done, and they work under those, they are valid, absolutely valid, under conditions of blinded placebo-controlled trials. But I do get pushback because they are subjective. And particularly when I'm talking to companies about outcome measures, it's sometimes difficult for them to get their head around the fact that this inherently subjective questionnaire completed by owners who could be considered to be ignorant of pain research are valid. And the reality is owners absolutely know their pets, just as human owners know their children.
Just as human patients.
Human parents know their children, and human parents don't necessarily know what's wrong with their child, but if the questionnaire is produced in the appropriate way, you can capture the information that they know, but they may not be able to directly communicate.
In the same way, a patient doesn't have to be an expert in pain research to be able to fill in a questionnaire about their pain. Any questions from the audience? Lady at the back.
Hi. It's a great question from an expert in this area. Thank you. So actually, I'll tell you, I'll be absolutely honest. The reason we looked at non-steroidals first was that we were absolutely set up to look at a novel molecule. Everything was there, and then the sponsor at the last moment switched out and said, you know what, we're not ready, but we do want to look at our particular non-steroidal for full disclosure, because they thought they may be able to get a label claim change. I was still interested in moving forward because I think, in the human clinical trials have shown that non-steroidals are not going to make any difference. And so for me, it was checking that box of didn't work in humans, didn't work in dogs. So that's the full honest answer of why I went forward. I thought there was still interest in doing it. It adds to our knowledge. I was honestly not expecting to see any change with the non-steroidal. Those data were part of a larger study where we were also looking at the effect of the non-steroidal on other measures, other QST measures. So we're looking to see, including temporal summation. So we were looking to see whether or not the non-steroidal changed any, if you like, spinal cord activity, this whole central sensitization. And so, yeah, it was all wrapped together in one study. Great question. No, we're just about to start a study with duloxetine, and also we have a study going with a novel molecular entity. Yeah, thank you.
So we'll have one more question, because we have a panel session after this, immediately following the next speaker. And the question is, what do you feel about quality of life scales alongside or in addition to, or maybe even instead of pain scores?
Yeah,
the one that's mentioned is Vetmetrica.
Yes. So I am not an expert in the quality of life measures. What I can say is that absolutely it's a very important thing to be capturing. I haven't talked about it because I'm not an expert. I'm not doing it. But the quality of life scales that have been developed by Vetmetrica and others are very important. Again, they're capturing a different dimension or multiple dimensions. And it's important to remember that it's not just, the quality of life is not only driven by pain, by many other factors.
Fantastic. Thank you very much.
Great question. Thank you.
Thank you.